We're going to call to order the Subcommittee on Communications and Technology for our hearing on health information technology harnessing wireless innovation. I want to welcome our witnesses and our participants in today's hearing. It's not every day the Subcommittee on Communications and Technology holds a hearing addressing FDA regulation, but the fact that we're having such a hearing is testament to the breadth of innovation using wireless smartphones and tablets and all that that's bringing to nearly every aspect of our lives. There are literally thousands of apps in the various smartphone and tablet app stores in the health and wellness categories, actually tens of thousands, everything from the simple calorie counters to complex analytical tools. The more than 300 million wireless devices we depend on every day are revolutionizing health and wellness. If I stopped here, this hearing could be about the success of bringing the innovation and investment of the wireless ecosystem to bear on the ever more costly healthcare system. And make no mistake about it, that could still be the outcome. But the specter of costly and time-consuming regulation, to say nothing of a 2.3% excise tax, looms large over this industry. We've heard from investors and wireless device manufacturers and application developers that are all concerned about the uncertainty of an FDA regulatory regime that may or may not apply to them and the possibility of an additional excise tax that cuts into already thin margins. The collision of these worlds in mobile health, or M-Health, is a study in contrast. The app economy is characterized by low barriers to entry, quick time to market, and the ability to adapt to quickly changing user needs. Medical devices, on the other hand, face a long and costly pre-market approval process at the FDA. Now, we all want to make sure that patient safety is taken care of first. But why would we treat mobile applications the same as a dialysis machine? These are the kinds of questions we need to get answers to about where that sweet spot is and that fine line. The answer may be that the wireless economy represents a tempting target for the 2.3% excise tax that the President's health care law placed on medical devices. While the IRS and the FDA have provided some draft guidance on how they will apply the medical device definition and the medical device tax, their analysis is not a poster child of clarity, and it leaves large parts of the economy wondering if they will be on the hook for what is essentially a tax on innovation. And we certainly are hearing that from our witnesses and others. The FCC and the Obama administration have both joined the wireless industry in trumpeting the virtuous cycle of innovation and investment in mobile technologies. Investment in wireless networks and devices creates opportunities for app developers to create new and innovative uses for wireless services, which in turn spurs further investment in network and devices. M-Health is part of this virtuous cycle that's driving faster speeds, lowering costs, spurring innovation, and creating patient benefits. Given the interconnected nature, we should be aware that an impact on one segment of this industry has the potential to slow the entire cycle. The overbroad application of FDA regulation and the healthcare law's medical device tax are not, as some have suggested, outside of the realm of possibility. In a 2012 report by the Institute of Medicine, one expert author suggested that all health IT products should be treated as Class 3 medical devices, which receive the highest level of regulatory scrutiny and therefore should be subject to the tax. Now, that's just one person's opinion, but it is in the prestigious Institute of Medicine report. Luckily, while these are not hypothetical concerns, they are also by no means foregone conclusions, which is why we're having the hearing today. Wireless has and continue to be a system that brings the mobile revolution to our nation's health and wellness sector. But we must ensure that as we bring the innovation of the wireless economy to health and wellness, that we not place unnecessary hurdles in the way of developers and investors that are fueling M-Health. So I want to thank our witnesses for being here, and I would now recognize the Vice Chair of the Subcommittee, Mr. Latta.
I thank the Chairman for yielding, and I also thank our distinguished panel for testifying today. The mobile application industry is a modern American economic success story. Just this year alone, mobile apps are projected to be a $25 billion industry. No one, at least no one in Washington, could have predicted the incredible growth and the extraordinary uses for these apps, particularly in the mobile health world. The health and wellness opportunities for mobile apps have great potential for our health care delivery system. I am concerned that the regulatory uncertainty coming from the FDA will discourage innovation and investment in mobile apps, and that Americans will lose out on potentially life-saving technology. This climate of regulatory uncertainty could also have adverse effects on the overall wireless ecosystem, which continues to drive economic growth in this country. Furthermore, I believe the medical device tax will be extremely detrimental to our economy. The potential application of the medical device tax to mobile apps will only further deter investment and development in the industry. Mr. Chairman, I look forward to our testimony today and to our witnesses, and I yield back.
Thank the gentleman for his comments. We now recognize the ranking member of the subcommittee today, Ms. Matsui of California.
Thank you, Mr. Chairman, and I'd like to thank the witnesses for being here today. Technology is changing healthcare as we know it. A smart spectrum policy that's driving wireless revolution is also transforming our healthcare sector. We're seeing the benefits of healthcare providers utilizing Wi-Fi and high-quality unlicensed spectrum to spur the development of next-generation patient care monitoring applications that could transmit patients' vital health data to their doctor or hospital. Whether it's monitoring diabetes, glucose levels, tracking blood pressure, or providing real-time hydration levels, the list goes on and on. We're seeing cloud technologies transforming health IT with the creation of select community health clouds forming in regions across the country, enabling hospitals to better treat patients while ensuring HIPAA-compliant transfers of secure medical information. It will only become more important as the mobile app economy continues to drive consumer demand for smartphone and tablets. The fact is, the ever-evolving app economy is helping to transform the healthcare sector, integrating science, medicine, and technology to provide individuals with real-time access to vital health information, much of which was previously unavailable outside of a hospital or doctor's office. House calls are becoming a thing of the past. Virtual checkups are becoming the new digital age house call. Doctors are using iPads to issue prescriptions and diagnose patients. Smartphones have created new paths of virtual interaction between doctors and patients. Texting your doctor has become a more common practice as more Americans, particularly our young people, are finding greater comfort and accessibility in communicating electronically with their doctors. The Affordable Care Act also has allowed the healthcare industry to become more innovative using technology. I believe we'll see a growing ecosystem of health IT innovation now the Affordable Care Act is here to stay. My home state of California has been a pioneer in ACA implementation. Our exchange, Covered California, has already begun using mobile devices to launch an online feature so consumers can estimate their monthly premiums and compare health care options. Physicians and hospitals in my district of Sacramento are using the exchange to improve their health IT capabilities. For example, the Live Health Online initiative already permits doctors to care for patients through a secure online visit using laptop webcams and ultimately through video-enabled tablets and smartphones, regardless of where the doctor and patient are located. With more than 50 million additional Americans expected to obtain health insurance this year due to the law, an efficient and effective health IT network is even more imperative. In order to realize the full potential of innovative health technologies, the regulatory environment must keep pace with rapidly changing technology. In 2011, the FDA released draft guidance to provide rules of the road for medical app developers, clarifying which medical apps would require its attention and which would not. I believe the draft guidance attempts to strike the appropriate balance between enabling innovative medical apps and ensuring patient safety, and I urge the agency to move forward expeditiously. Now, moving forward, I believe the FDA must be mindful of the fact that technology continues to evolve at a rapid pace and the need for them to provide clarity to the marketplace. Another way to foster greater innovation in the health sector is through creating a workable federal definition for telehealth services. I'm developing legislation to do just that. I believe having certainty here will spur innovation and research in the private sector and in programs like Medicare. We must continue to chart a technology-friendly course that promotes better patient care for all Americans. And, Mr. Chairman, I'd like to ask unanimous consent to enter into the record the following 3 items. A report from the Center on Budget and Policy Priorities on the Medical Devices Excise Tax, a letter from SDI Diagnostics, a small medical device manufacturer, regarding FDA regulatory oversight of the medical device market, a study published in the peer-reviewed journal JAMA Dermatology, identifying risk and depending on smartphone apps for diagnoses.
Without objection.
Thank you, and I look forward to working with my colleagues to continue to promote health IT. Look forward to hearing from our witnesses today. Thank you. I yield back.
Gentlelady yields back balance for time. Chair now recognizes the gentlewoman from Tennessee, Ms. Blackburn, for 5 minutes.
Thank you, Mr. Chairman, and I want to thank our witnesses for being here today. We are deeply appreciative that you all are here, and we're appreciative of what you're doing in the industry and in this space in which you're working. You know, I was stunned in doing some work on this and talking with some of the innovators in Nashville. 500,000 jobs are attributed to your sector. And you're one of the few areas where there's actually been some jobs growth since the misery that was there in 08 and 09. And, you know, when you look at mHealth, you're talking about a $27 billion industry within the next couple of years. So we thank you for this. Not only is it productive, and not only is there opportunity to profit from your innovations, there is the opportunity to encourage R&D and to provide better outcomes and better wellness and maintenance of effort in health, to expand the use of telemedicine and mobile health. And so hearing from you where you think we need to travel with this is going to be helpful, and it's going to be instructive as we look at this entire space for healthcare informatics and the opportunities that exist there. I think that, you know, we're all concerned about what would happen with the medical device tax being applied to this. Of course, it's muddy as muddy water when you're trying to figure out where the FDA is actually looking to go. I know there are about 300,000 apps that are available, or 80,000 apps, I think it is, and 300,000 downloads that are through the Apple App Store. And so people like the convenience of this. And we want to do what we can to make certain that it remains accessible and affordable and is not levied with a tax that is going to end up being a hindrance. So we appreciate your ability to make way for us in your schedules to be here. And Mr. Chairman, I yield back.
Would the gentlelady yield? Thank you. I would just like to weigh in. The medical device tax is a very pernicious tax by itself. One of the problems I have is the gross nature. Taxing just gross versus obviously net after cost and expenses. I mean, it's where else but in Washington can you dream up such a bad tax provision, tax law. But as was stated earlier by my colleagues, what's critical for you all in your testimony today is kind of to help us sort through your concerns, your risk, your level of being able to capitalize or not, and then where is this line? I mean, it's very vague, and so when there is uncertainty, there's higher risk. When there's higher risk, there's a more cost of capital, and it could be damage to any business model that you would address. So we really appreciate you being here. We're probably going to ask some pretty specific questions, especially for those of you who are in that space, innovating and creating jobs. We thank you for coming in with that. I go back to my
for
colleague.
Yielding back. Did Mr. Lance or one of my other colleagues want any of the remaining time? Okay. Mr. Chairman, I yield back.
Gentlelady yields back. Chair now recognizes the former chairman of the committee, the gentleman from California, Mr. Waxman.
Thank you, Mr. Chairman. This is a hearing to look at mobile medical applications. And this is the first of 3 hearings on this subject this week. The high-speed wireless broadband access is creating new opportunities and consumer services in nearly every segment of our economy, including healthcare. And mobile medical applications hold incredible promise for patients and healthcare providers, potentially reducing costs, improving healthcare delivery, and saving lives. That's why we made a significant investment in medical communications, because this is a really important area. We all want to see this exciting innovation continue. At the same time, we have to be cognizant of the need to protect patient safety. That's why the Food and Drug Administration has released a draft guidance regarding mobile medical applications. So their guidance says if it's a dietary tracking app or a reminder service for medical appointments, you certainly don't need FDA approval for that. But an app that purports to diagnose cancer, well, there ought to be some review and have regulatory scrutiny. Let me give an example. A group of dermatologists recently published a study of 4 apps that claim to be able to diagnose melanomas. Well, the dermatologists found that 3 of the 4 incorrectly classified 30% or more of melanomas as benign when they were actually malignant. Well, we can't tell the American people, buyer beware, when potentially life and death care decisions are at stake. My Republican colleagues say that FDA is hoping to subject smartphones and tablets to the medical device tax. Well, that doesn't really hold up to scrutiny. I think they have their facts wrong. Allegations that ordinary smartphones and tablets could be subject to added red tape or new taxes under Obamacare are absolute myths. In fact, FDA's draft guidance specifically states that the agency does not intend to regulate distributors of mobile medical apps like the iTunes Store or the makers of smartphones or tablets like Apple. Smartphones and tablets are not listed with FDA as medical devices, so they're completely outside the scope of the medical device tax. Furthermore, it's my understanding that most mobile medical apps would also be exempt from the medical device tax because of the IRS, quote, retail exemption, end quote. This provision says that devices are exempt from the tax if they are regularly available for purchase and use by ordinary consumers, including over the Internet, and if they are not primarily intended for use in a medical institution or by a medical professional. So go back to the case of the dermatologists. Those apps would not be subject to the medical device tax, but they would be subject to FDA scrutiny to be sure that the patients are not being harmed. There are legitimate concerns we ought to examine. Instead of using today's hearing to invent new fallacies to attack the Affordable Care Act, we've already had a number of hearings this year on attacks on the Obamacare. Well, my Republican colleagues didn't like it. They all voted against it. They hoped the Supreme Court would have thrown it out. The Supreme Court upheld it. They hoped the election would have replaced the president so they could have repealed it. The electorate voted for President Obama. This is all going to go into effect at the end of this year, to be fully in place by January of 2014. We've already seen a lot of improvements in health care by virtue of the Affordable Care Act. The Affordable Care Act is going to serve a very important purpose. It is not going to require mobile apps to be regulated or to be taxed. FDA released a draft guidance for mobile medical apps, and we should commend them for this action. Both industry and consumers would benefit from the clarity of final guidance. I hope that FDA is working expeditiously toward that goals. You have to make distinctions. You don't blur it all to serve a political point of view to attack the Affordable Care Act. We've got to look at the law, draw the distinctions, and make sure that the public is protected while innovation is still encouraged. And I think that we're looking to a lot of very important innovation, and we want to see that come into action. Thank you, Mr. Chairman. Yield back.
Gentleman yields back the balance of his time. The Chair would ask unanimous consent to enter into the record a letter from the CTIA CEO and former Representative Steve Largent raising concerns of the wireless industry, and a letter from Keith Brophy, CEO of IDAMED from Grand Rapids, Michigan. It's a medical app device developer, and also has concerns about the uncertainty, which is why we're having this hearing today. Without objection.
Yeah. Mr. Chairman, I certainly have no objection. I just wanted to point out to the witnesses that there's another hearing going on, so I'll be back and forth, and I apologize for not being here the full time.
No problem. Feel free to take the full time in the other hearing if you'd like. No, I'm just... We actually have a little fun together here, so it's fine. No, thank you. And we've got other members that are going to be coming and going. It's a good reminder because there is an Energy and Power subcommittee meeting as well. So with that, we welcome our witnesses. And I know Dr. Daggie's plane was a little delayed getting out of Boston. Apparently a little snow up there, but he has arrived, and so he'll be joining us momentarily. But we'll go ahead. And again, we thank you all for being here. I've read through your testimony. It's most helpful in our efforts to shine some light on this issue. So we're going to start with Mr. Robert Jaron, Senior Director of Government Affairs for Qualcomm. Mr. Jaron, we're delighted to have you here this morning and look forward to your testimony, sir.
Thank you. Good morning, Chairman. Excuse me. Good morning, Chairman Wallen, Ranking Member Matsui, and members of the subcommittee. First and foremost, I'd like to thank you for having me participate as a witness in today's hearing. I've worked in various capacities over the span of 2 decades, at times preparing others to sit before you. Today, I'm truly honored to be the one sitting here. I'll begin by starting with mobile technology. It is the largest platform in the history of mankind. The population of the world is approximately 7 billion people, and there are nearly 6.6 billion mobile connections. In the U.S. alone, there are 323 million mobile subscriptions for a population of 315 million people. Consumer research suggests that 2/3 of people sleep with their mobile device next to them, and 1/3 interact with their device before they even get out of bed. Those with the mobile phone tend to check it about 150 times per day, roughly about once every 6.5 minutes. Mobile devices are powerful and sophisticated. Today, a typical smartphone has more computing power than Apollo 11 did when it landed on the moon. Computing devices are now built around mobile experiences with always-on connectivity, location awareness, augmented reality, and powerful processing. Soon there will come a day when virtually everyone and everything in our world will be connected through a ubiquitous wireless technology. Let me also share some startling statistics of a different nature, yet related. Chronic disease in America. According to the CDC, about 1 out of every 2 adults in the U.S. has at least one chronic illness. 7 out of 10 deaths among Americans are due to chronic disease. Obesity, for example, affects 1 in 3 adults, as well as 1 in 3 children who are either overweight or obese. Although chronic diseases are among the most common, they are also the costliest of all health problems. The CDC states they are also among the most preventable. This presents an interesting opportunity. Many Americans are sick, yet more have access to a personal, powerful mobile computing device. Hence, it was only a matter of time before the healthcare technology innovators would take notice of the potential to personalize a mobile platform and facilitate the delivery of affordable healthcare. Nowhere is this growth more obvious than in the mobile health applications landscape. Quite simply, the growth of mobile health apps has skyrocketed. Approximately 27,000 unique health apps are available. Over 7,000 health apps are specifically intended for use by students and healthcare professionals. 500 new mobile health apps launch every month. Interestingly, however, a survey conducted by Mobile Health News shows that to date, FDA has only cleared fewer than 80 mobile medical apps through its 510K process. They further estimate that as little as 5% of all health-related apps could potentially be considered medical and possibly subject to FDA regulation. On July 21, 2011, the FDA issued a draft guidance on mobile medical applications. The agency went on to receive more than 700 pages of comments from over 100 interested stakeholders. They also held a 2-day workshop and engaged the public at large in briefings and events. FDA officials have expressed their views that the final MMA guidance would be deregulatory. In effect, it would delineate how the agency would exercise enforcement discretion to not proactively regulate many low-level risk mobile medical apps. However, it is now March 19th, 2013, and unfortunately, FDA has yet to release a final MMA guidance document. Qualcomm and others are concerned that the failure to release final guidance has created uncertainty among countless budding entrepreneurs and large corporations that fear the prospect of facing FDA regulation. Qualcomm offers the following recommendations for consideration. First, FDA should promptly finalize the MMA draft guidance document. Second, the final guidance should offer specific examples of low-risk, regulated mobile medical devices that FDA, through enforcement discretion, would not regulate. Third, there should be clarity on intended use in light of ambiguous and general health claims and terms. Fourth, for apps that do not warrant listing as low-risk Class 1 medical devices, or that do warrant listing as low-risk Class 1 medical devices, the agency should consider how it will assess exemption from good manufacturing practices. Fifth, accessories should be classified according to their individual level of risk and not according to the device with the highest classification level. Sixth, FDA should continue its commitment to consistency, predictability, and transparency by coordinating internal and external efforts through a single dedicated office within the agency. Seventh, and lastly, the agency would benefit to utilize external-facing resources such as CDRH Learn, Device Advice, and the Division of Small Manufacturers, International, and Consumer Assistance to work with app developers and their communities. FDA has a proven and successful policy, regulatory, and legal framework that's been formed from over 100 years of innovation, science, and learning, a framework that puts the patient first, ensures safety and effectiveness of all health and medical products in the U.S. marketplace. We recommend that FDA be given the fullest support it needs to continue doing its fine work while allowing innovation to drive the U.S. healthcare system. In closing, I would like to say a few words about Qualcomm. Qualcomm Incorporated is a leading supplier of wireless chips, having shipped worldwide well over 11 billion chips to date. Qualcomm is a leading developer of 3G, 4G, and other next-generation wireless technologies. In addition, Qualcomm has a wholly owned medical device subsidiary focused on producing medical device data systems. We are committed to the healthcare space through various public and private efforts, as further described in my written testimony and on Qualcomm's website. Thank you, and I look forward to answering your questions.
Mr. Jaron, thank you for the thought you put into your testimony and for being here today. We'll go now to Mr. Bradley Merrill Thompson, General Counsel, M Health Regulatory Coalition. Mr. Thompson, thank you for being here today. We look forward to hearing your testimony.
Well, thank you very much for inviting me. And as you can tell from the name of our organization, the topic today is of very great interest to us. Our coalition is a very diverse coalition, which is both fun and challenging. It's fun because we have a lot of spirited discussions. It's challenging because it represents a lot of different points of view. We have folks in there from the traditional medical device industry. We have app developers in there. We have the telecommunication firms in there, patient groups, and so forth. And frankly, the way I navigate consensus building in our group is to say, look, we only have one rule, and that is put the patient first. Leave economics at the door, and let's figure out what policy puts the patient first. In that vein, I have three simple points that I want to make this morning in my testimony. The first one is that we would urge FDA to publish its guidance just as soon as possible and indeed expand on that guidance in the future. I cheated a little bit and I read the testimony of my other fellow witnesses here, and it seems like there's going to be good agreement on that score. What I would offer as the nerdy lawyer maybe among the panel is that I think that maybe FDA is delaying because they're going for the complete and final definitive for all time answer to these questions. And it's really tough because the industry changes on almost a daily basis. So they write a draft, it goes through a couple months of review. By that couple months, the environment has changed a bit, and they want to go back and erase some of what they wrote previously. I think what they need to do is get a final version out there and then use the guidance process to update it periodically. As the environment changes, as the regulatory issues shift, as the questions shift, simply update the guidance periodically. We've talked about creating a website where they would, on a more real-time basis, offer some guidance. There's some tools that are available to them, but bottom line is I think FDA is struggling a bit with how to get this guidance out. And in our opinion, it needs to get out because there's an awful lot of business that is frozen on the sidelines waiting to see what that guidance says. The second point I want to make to you is a bit counterintuitive probably for someone from industry to say, and that is we'd like to see more FDA enforcement in this area, and particularly more balanced FDA enforcement in this area. And the way I can make this point is best through an example, and it's an example I read about of a new app just a few weeks ago announced from India, where you can do urinalysis with your iPhone. And everyone was talking about it on the internet because I think a lot of people were trying to figure out exactly where you pee on this thing in order to get the reading. And it turns out you do it by a very traditional technique. You pee in a cup and put a strip in that cup. It changes color, and then use the camera on the iPhone to more accurately assess what the color changes were. And they introduced this thing. It hasn't yet hit the U.S. market, but they've announced their intention to go through the Apple App Store in introducing it. The problem is FDA has regulated urinalysis for 30-some years. That's a very traditional medical device. And the typical one looks about the size of a cash register. So I got to tell you, doing it on an iPhone, that's cool. That's really cool. But what they did is on the front page, at the bottom of the front page, they basically said in legalese, this is not a medical device. Well, honestly, if it were that simple, I know a lot of other companies that would like to do that same thing, right? If you could avoid FDA by putting a disclaimer at the bottom of your home page, and yet the whole rest of the website explain how it's used in your analysis, that's a problem. So this is in part a competitive issue, right, because different companies held to different standards, but it's a public health issue because this is an important app. And if it gets the urinalysis reading wrong, people with diabetes, people with serious conditions could be relying on that app. So either deregulate it, which would take an act of Congress, I believe, because it's clearly a medical device, or more evenly enforce the rules. The third and final point that I want to make is that we favor sticking with FDA as the regulator for both the traditional device industry and the less traditional M-health area. There was a rumor circulating, and who knows where these start, but that people wanted to move mobile health regulation away from FDA. We couldn't support that. We couldn't support it because it would create two systems where if you do it on an iPhone, it's one system. If you do it on a cash register size machine, you have a completely different system. To us, that actually increases the uncertainty and the complexity and the confusion. And so we found that FDA has the knowledge that they need. This is a new technology. We're all learning the technology, but they have the public health knowledge in order to do this and to do it right. So we favor sticking with the agency. Those are the 3 points I wanted to make this morning, and I appreciate the time.
Mr. Thompson, thank you for your testimony. We'll now go to Mr. Ben Choder, who's the Chief Executive Officer of Haptique, like Health App Boutique.
Exactly.
Haptique. Everybody with me now. All right, Mr. Choder, you're on.
Good morning, Mr. Chairman Walden and Ranking Member Mitsui and members of the subcommittee. My name is Ben Choder, and I'm the CEO of Haptique. It's an honor to testify today on mobile health technology, which Haptique believes can change healthcare delivery system. My testimony addresses two important issues facing our industry.
Will you make sure your microphone's on?
Yeah, is that better?
No.
Is that better? There we go. All right. My testimony addresses two important issues facing our industry: questions around regulations and the applicability of medical device tax to mobile devices. Haptique is a mobile health solution company whose mission is to integrate mobile health into patient care in daily life. Haptique is owned and operated by GNYHA Ventures, a business arm of Greater New York Hospital Association. GNYHA has a robust family of companies to assist its members in addressing business and operational issues. Haptique, the newest member of the companies, was established in direct response to members' needs to develop comprehensive mobile health strategies to support clinicians, facilitate patient engagement, and improve their own operations. Haptique's principal offerings include individually branded, secure, multi-platform application stores for hospitals, physicians, and patients. Our MRX, it's our patent-pending technology that enables physicians to actually prescribe apps to their patients. A unique system of classifying apps in more than 300 categories. And our brand new private sector solution to a big problem, we've just launched our certification program for health apps. Haptique created these solutions to harness the unprecedented potential for mobile health technologies. Think about it, 87% of physicians use smartphones or tablets every day. 1 out of 5 smartphone users has at least one health app on it. There are over 40,000 health apps in exist on the market, and it is growing every day. And there is little to no barrier of entry for these apps. This has an incredible opportunity for innovation in healthcare, but comes with certain concerns, namely, how credible is this app for myself or for my patient? So who should monitor, mobile health industry? Clearly, the industry needs to balance three things: innovation, safety, and effectiveness. The FDA released its guidelines in 2011, which Mr. Jaron went over, and Optique's belief is that the FDA is in the best position of any agency to regulate health apps because of its long-held expertise in assuring patient safety. But we have to say, from our point of view, the FDA has to release these guidelines sooner than later. It's about time that they come out. We don't believe that the FDA should regulate M-Health products that are not considered medical devices. The FDA's draft guidance addressed which mobile apps the FDA does not anticipate classifying as mobile apps for purpose of regulation. The industry is pleased that the FDA recognizes its own limits. Complementary to the FDA regulatory framework, Optique, our company, has created a certification program with industry stakeholders to offer clinicians and patients a way to identify technically and validation of an app. Optique developed a health app certification standard under the direction of a blue ribbon panel, and we're reviewing operability, privacy, security, and content. In the development of the standards, we consulted with key public-private sector organizations, the FDA, the FTC, the FCC, the ONC, the AMA, the AAMC, and many, many other organizations. This conducted the certification process. Again, Optique is engaged, well-known security company to ensure operability, privacy, and security, and we are engaging specialists. So if it's a cardiology app, cardiologists should review the material. Apps that pass both the technical and testing content review were rewarded the Optique certification seal. Our goal here is that the users will be reassured that a certified app delivers credible content, safeguards user data, and functions as described. I'd like to switch gears for a second and now talk about the medical device tax and how it relates to mobile health apps, since I know several members of the committee also care a great deal about this issue. Optique does not believe Congress intended to impose the device tax on iPhones, iPads, Android phones, or tablets, or BlackBerries, or apps that run on these devices. Even if congressional intent is ambiguous, we firmly believe the retail exemption applies. If the IRS wants to implement this tax on this technology, Congress needs to pass a law that specifically states the tax applies. Imposing a device tax on apps will undoubtedly stifle innovation. Developers and publishers, and frankly, the threat of tax stifles innovation too. In closing, thank you for my allotted time, and I'd like to thank the chairman and ranking members and the subcommittee for asking me to testify today.
Mr. Schroeder, thank you for your very good testimony, and that's why we're having this hearing, is to try and shine some light and bring some clarity. Mr. Jonathan Spalter is next. He's the chairman of Mobile Future. Mr. Spalter, thank you for being here.
Well, and thank you, Chairman Walden, and members of the subcommittee for giving me the opportunity to testify on behalf of Mobile Future and our member companies. My name is Jonathan Spalter. I'm chairman of Mobile Future. We represent innovators across the wireless ecosystem. And I sit before you, I think, at a very, very hopeful time for our community. It's now believed by many scientists that there's already been a child born in the world who will live to 150 years old. What an exciting notion for our children and our grandchildren. These leaps and bounds in the quality and the quantity of our lives are in no small part due to the astounding progress we are all witnessing at the nexus that we're talking about today of healthcare and mobile innovation. This morning, I'd like to focus very practically my comments on what mobile innovators need from government to help us all advance our health. We know that the virtuous cycle of investment in the mobile ecosystem, from networks to devices to applications, provides an unparalleled foundation for health innovation. And I believe government can help build on it by providing our mobile health innovators 4 key and achievable certainties. First, a clear understanding of where regulation begins and where it ends. The Mobile Medical Act guidance now has been pending for 2 years. Clear guidelines and regulatory certainty are needed now. common sense and affordable approval processes that are measured in months, not in years. Timely decisions across government that, of course, encourages a careful balance to safeguard patient safety and privacy on the one hand, which we all care about, without inhibiting the development and use of mobile medical apps. And finally, basic fairness when it comes to the taxes we pay, all consumers pay, on wireless services and applications. Bottom line, Americans would benefit from clear guidelines on when applications go to which government agency and for what set of approvals. But let's not also forget that none of this progress would be possible without spectrum and without investment. And therefore, it's imperative that the incentive auctions which are being designed now at the FCC are open and inclusive so that all Americans can take advantage of wireless health applications. And it's also worth noting that the needed spectrum is held by government agencies, significantly held by government agencies. So all of our eyes, all of America's eyes, are on the federal agencies who hold much of this underutilized spectrum, hoping they will make a meaningful contribution. I know that all of us can personalize this progress that we're talking about today. My daughter Willa was diagnosed 2 years ago at age 8 with type 1 diabetes. She's been extremely fortunate that from her very first week with the disease to have been in a clinical trial at Stanford University that's pursuing the holy grail of diabetes research, the artificial pancreas. Even having worked in mobile innovation and technology myself for years, I wasn't prepared, my family wasn't prepared for just how personally and profoundly relevant mobile innovation would become so quickly to my daughter. On the first day of her trial, there was her endocrinologist, Bruce Buckingham, and her research nurse, Jen Block, explaining the research and the hope that it holds for 3 million Americans who are dealing with this disease. And then, Dr. Buckingham, not really knowing what I do for a living, spoke about the importance of spectrum as he explained the wireless sensors that were all around my daughter's hospital room and the wireless glucose monitor that she now wears in her body. The medical team included software coders, application developers, algorithm writers, network engineers, all pushing together towards what could be, and I indeed hope will be, nothing short of a revolution in diabetes management. And this is the future of American healthcare. We all have a personal stake in speeding its progress. And ultimately, this is not about government stepping away. Rather, it's a profound opportunity for government to lean in and demonstrate that it, too, can innovate, that it can act flexibly, that it can move quickly with common sense, and with the understanding that innovation is born of many, many things, including a healthy dose of humility and restraint when it comes to regulation. So, on behalf of application developers and wireless innovators across our country, on behalf of my little girl and the millions of Americans who are managing chronic diseases, I really thank you for the opportunity to testify about our nation's promising mobile future, and I really look forward to your questions.
Mr. Spalter, thank you for sharing your very powerful story with us. It really sheds clear light on our task here, and of course it also shows we are the most important subcommittee in the Congress, as we did make available new spectrum, and we're continuing to pursue the government excess spectrum, as we might find. Too.
And that has the added advantage of being true, Mr. Chairman.
Thank you. You know, you're welcome to come back on a weekly basis. Yeah, let's do this. So, no, seriously, thank you very much, and thanks for the work you're doing. We'll go now to Dr. T. Forchdaghi, I believe, MD, MPH, DMD-SC. I'll let you explain all of those things. Partner at HLM Venture Partners. We're delighted you were able to get another flight and get down here from Boston. Thank you very much. Go ahead and push that button in front of you there.
Thank you, Mr. Chairman. Chairman Walden, Ranking Member Eshoo, members of the subcommittee. I'm Dr. Teo Forchdaghi. I'm a partner of HLM Venture Partners based in Boston, Massachusetts and San Francisco, California. I'm a board-certified neurosurgeon trained at Johns Hopkins and the Massachusetts General Hospital and hold or have held leadership positions in clinical and academic medicine for over 20 years. I'm chair of the Committee on Perioperative Care of the American College of Surgeons at present, and I hold a professorial appointment at Harvard Medical School. On behalf of HLM Venture Partners, the venture industry, and the entrepreneurial community, and also as a physician devoted to the betterment of health care, it's my privilege to testify before this committee on the subject of mobile medical applications, MMAs. Venture capitalists are committed to the funding of America's best and most innovative entrepreneurs. They work closely to transform breakthrough ideas into emerging growth companies that drive job creation and economic growth in the United States. One of the top priorities for healthcare and life science investors is to work and discover innovative solutions that address unmet medical needs, enhance healthcare outcomes, and lower overall healthcare costs, while preserving the safety and the quality of the American healthcare system. For investment to grow in the formative stages of emerging medical mobile applications, there need to be well-defined regulatory pathways to market. Uncertainties in the regulatory environment create significant risk for innovative companies and deter investment in many promising ideas. We believe that regulatory pathways should be risk-based, transparent, consistent, predictable, and above all, balance the problem of patient safety and its protection against innovation. I believe that medical mobile applications will prove to be a central, important, and potentially critical tool in optimizing communications among clinicians and especially between clinicians and patients. Also, they will help broaden and sustain shared decision-making, which is a critical part of any type of healthcare reform. I believe that MMAs will prove invaluable for patient engagement and education. They can materially enhance integrated strategies for healthcare, help coordinate the management of chronic disease, and promote patient safety while lowering healthcare costs. Here are some examples of the critical roles they already play. They're used to help diabetics follow and refine insulin regimens. Mr. Spalter, I didn't know you were going to speak to that. Thank you. They're used to screen for diseases of the retina, for telemedical consultations, to help patients with congestive heart failure avoid readmission, to diagnose moles and screen for cancer, and to coordinate across groups of physicians in different institutions. They provide a means for sending sentinel emergency alerts to providers. They also facilitate home health care and remote monitoring of patients in other settings like the intensive care unit. They hold tremendous promise in patient care, and I emphasize in safety. I would also like to emphasize my concern about the 2.3% medical device tax with regard to medical innovation and U.S. job creation. We also believe Congress did not intend to burden emerging MMA companies with this new tax. Their products are not included in the traditional medical devices. The 2.3 tax on revenue has already started to have detrimental effects on early-stage medical device companies. They are regressive and repressive. It creates a major market inefficiency by increasing the capital intensity of innovation and discourages venture capitalists from investing in these companies now and in the future. The tax would be even more devastating for companies developing MMAs because of their revenue structure. The tax of 2.3% sounds modest, but it is not. This is a tax on revenue. It is not a tax on profits. The vast majority of entrepreneurial ventures developing MMAs are very small and very early. Some of the companies in which we invest may in fact generate some revenue, but very unlikely to generate profit. Revenues are plowed back into the company for growth, and therefore the 2.3% tax on small startup companies delays their ability to reach profitability and increases the amount that must be invested before a company can become cash flow positive. Venture capitalists and entrepreneurs stand ready to participate along with other public and private stakeholders to find solutions that will help move these important innovations into the healthcare system. We would like to offer the following recommendations to help stimulate investment in this very important sector. First, promote a regulatory framework that is predictable, consistent, transparent, and risk-based. The Food and Drug Administration issued draft guidance for mobile medical applications on the 21st of July 2011. This guidance addresses some regulatory concerns and reduces some regulatory uncertainty, but leaves open questions around enforcement discretion decisions. The uncertainty must be resolved. Second, the FDA and other stakeholders are encouraged to collaborate and formulate alternative oversight frameworks that meet the goals of patient safety in mobile medical applications, but also encourage and foster innovation and invention. Third, we would ask that the FDA solicit very broad input in evaluating new regulatory frameworks, especially from those at the forefront of innovation that promotes healthcare transformation. And finally, we would ask that mobile medical applications that are defined as medical devices be exempted from the 2.3% medical device tax. Mr. Chairman, Member Eshoo, members of the subcommittee, thank you for the opportunity to testify. I look forward to working with you to address these critical issues.
Dr. Nagy, thank you very much for your very learned testimony. We'll now go to Dr. George Ford, who's the Chief Economist, Phoenix Center for Advanced Legal and Economic Public Policy Studies. Dr. Ford, we're delighted to have you. Please go ahead with your testimony.
Chairman Walden, Ranking Member Matsui, and members of the committee.
You may need to push the button there.
I have.
There you go.
Thank you for the invitation to speak today and appear before this committee again. At issue in this hearing is the role of FDA oversight in health-related applications for mobile devices and the platforms on which they run. mHealth applications are believed to have great potential to promote better health and improve the efficiency of the healthcare system. mHealth can also help address the documented health disparities in lower-income segments of the population where the provision of health services and treatment compliance can be challenging. In my testimony today, I touch upon a couple of thoughts about the possible regulation of mobile applications and platforms as medical devices by the FDA. First, by its very nature, regulatory intervention into mHealth by the FDA will have direct implications for the nation's mobile communications industry. Mobile applications, mobile devices, and mobile networks are all part of the mobile communications ecosystem. In greater or lesser degree, to touch one is to touch them all. The United States mobile industry is a true American success story, and the mobile app economy is said to employ about 500,000 persons. Many believe that the continued growth in the mobile sector, both in size and innovative capacity, is critical for the U.S. economy. One study suggests that the diffusion of new technology in mobile wireless communications supports about 400,000 jobs annually, and the billions invested annually in mobile and fixed networks supports and creates hundreds of thousands of jobs. Accordingly, regulating mobile applications is not only a healthcare issue, but a much broader economic one. The difference between a good decision and a bad decision regarding the FDA's regulation of the mobile sector may have significant economic impacts. Indeed, economic theory and an ample literature demonstrates that the inevitable and arguably intended effect of FDA involvement is to raise the cost of innovation, to alter the trajectory of innovation, to reduce competition, and to favor larger firms that can afford the overhead of dealing with a federal regulatory agency. In a trade-off with efficiency and efficacy and safety, these negative effects may be acceptable. Gains from improvements in safety and quality may be sufficient to offset the lost innovation and higher prices from less competition. Normally, the cost-benefit trade-off is limited to the health sectors, but in the mobile ecosystem, the FDA's intervention could spill over into the entire mobile broadband industry. The dangers are significant, and I applaud this committee for taking this matter seriously. Second, while the scope of the FDA's regulation of mHealth is a complex issue on its own, the decision is made even more complex by the Affordable Health Act's medical device excise tax. Regulation and taxation are completely different questions, and there is no reason to believe and every reason to suppose that the proper methodologies for choosing when is appropriate or not will be quite different in scope and severity. Taxes may or may not raise revenues, but taxes always discourage the activity being taxed and play no apparent role in assuring the safety of the product being sold. Yet the role of the FDA in assessing mobile health applications cannot be treated today as independent of the tax question, since defining applications as medical devices may very well lead to the taxation of such applications under the Affordable Health Act. In addition, given health disparities for low-income Americans and given the expectation that mHealth will be particularly effective with low-income Americans, the medical device tax may prove to be a regressive tax. Moreover, the medical device can be described, or what I describe, as a virtue tax. Normally, the government applies taxes to items it wants people to consume less of, that is, sin taxes. The medical device tax, in contrast, applies to items a government agency has declared to be good for people. If we want innovation to drive a healthier America, then why tax such innovation? It doesn't seem to be very good policy, perhaps doing more harm than good. Finally, and perhaps most significantly, I believe the FDA's draft guidance leaves the door wide open for inserting the FDA into the innovation flow of mobile handsets, tablets, and other devices, or what we refer to as platforms. There are good reasons to believe that formal role for the FDA in the mobile handsets and tablets would significantly curtail the pace of innovation in that sector, an innovative pace that is rapid and highly beneficial. My written testimony discusses this concern in detail. A critical question is, could a regulator or tax collector, or even an overzealous regulator or tax collector, make a legally defensible argument that these general purpose devices, or even the entire mobile network, are medical devices and thus subject to regulation or the medical device tax? In an ecosystem like the wireless industry, where all the components are tightly intertwined, where does the line get drawn on what is and what is not a medical device? Obviously, clarity is needed, and there needs to be some limitations on the scope of the FDA's reach, lest regulation and taxation become very broad in the mobile ecosystem and do significant damage to innovation in the sector. Mr. Chairman, thank you again for the invitation to testify today. I welcome any questions.
Dr. Ford, thank you very much for your testimony and that of all of our witnesses today. I think it has helped explain why we're doing this hearing to begin with, because we kept hearing that there's a lot of uncertainty in the marketplace that may indeed be slowing down, stifling investment, innovation, and new U.S. Job growth and technology. So that's why we're doing this hearing. And I know Mr. Waxman, who had to leave, and I understand that we all have to juggle here, thinks the law is very clear. Obviously, you all don't, especially when it comes to the FDA's lack of a final rule in this area. Look, we're all for patient safety. There's no separation here. We're all patients eventually. We want patient safety. We don't want fraudulent devices on the market. We recognize the importance of appropriate regulation. But Dr. Ford, I thought it reminded me of something I always was told: if you want less of something, tax it more. And you know, you really summed it up and basically said, look, you're taxing innovation in healthcare. Don't we want more of that? Is that not what you were?
Yes. Well, it's
and a gross receipts tax, which could completely stifle innovation.
The gross receipts tax will significantly deter involvement of companies in this space. It's a fairly severe tax, particularly when we're dealing with innovation, new products, new companies, and even hospitals and doctors that themselves have entered into the business to design their own applications. This virtue tax issue is an interesting one, and I think I mean, it's weird when you have a government agency say, okay, here's the good stuff, and now we want you not to use it so much.
We've run into that in my own state of Oregon. There was a medical device manufacturer who, for various reasons, but they said, including the new gross receipts tax, I believe laid off, a couple hundred people already, and I'm hearing about it around the country. Dr. Daghi, are you seeing a move to take this offshore in terms of innovation and development and offshore these jobs and all that now, or not?
I am, sir. Seeing two things. We're seeing that many companies attempted to take this offshore, and they're also thinking about launching offshore where profits will not be taxed and where the regulatory path is both simpler and more direct.
So is it accurate to say that Obamacare is driving this sort of medical technology and innovation to other countries? because
I'm not
of this
expert
tax?
enough to say that it's Obamacare specifically.
Well, but the 2.3% tax is
Yes,
part
sir.
of the President's health care law.
Yes, sir.
All right. And so, Mr. Spalter, what does that mean, people like your daughter and the innovation that could come from that? Are you concerned about a reduction in innovation in this area, and that these really smart people who are probably, I don't know, 14, sitting in a garage somewhere creating apps are going to go create another Angry Bird as opposed to something in this area? I mean, and I'd open that up to anybody here. That's my concern, is that public policy has an impact. Is it going to have a negative impact here, which is not what we want?
America's wireless consumers, all of us, are actually paying roughly 17% of our monthly bill towards for our wireless services to taxes. Wireless services are taxed at 2.5 times other goods and services on average across our country. We're very concerned, Mr. Chairman, that these types of taxes, if they are applied to mobile medical applications and devices, will stifle innovation, will tempt entrepreneurs to pursue, as you suggested, other types of innovation and apply their genius and their efforts to other parts of the mobile ecosystem, rather than efforts to make our children, our families, our parents healthier. So there is an impact, and we need to be very, very vigilant and cautious about going down this path.
Mr. Jaron, in your testimony, you mentioned that as many as 5% of the 27,000 health-related apps could be subject to regulation. Yet, as our data would indicate, fewer than 80 medical apps have gone through the FDA process. I was a journalism major, not a math major, but I think that leaves 1,200 apps in a state of regulatory uncertainty.
Correct.
Roughly. Is that accurate? And are you
accurate.
concerned about the time delays and all of that?
Yeah, we're very concerned about the fact that we haven't gotten any clear guidance. You know, the draft guidance document needs to be finalized, and we were hoping that through that finalized document we would have a better understanding of whether or not these apps that are on the market should be regulated, or the agency will use their enforcement discretion to not regulate them. And that's a very important thing, because when you're talking about a device, a medical device will always be a medical device. It's up to the agency whether or not they're going to proactively regulate that medical device. And I'm speaking about the very low risk end of devices, not medium risk or higher risk devices,
Right.
which I think we all agree are not the ones that
Right.
we're discussing. But when we're talking about a mobile application, a health application, there's a lot of ambiguity. For example, if I were to use some of the terms like well-being in my marketing claims, or heart health or sleep deprivation, or patient satisfaction, stress, even mention
Did those trigger FDA?
Unsure.
Potentially?
Unsure. And that's
Wow.
the kind of clarity that we're looking from the agency. And they seemingly were ready to deliver that clarity. I believe in this very building less than a year ago, Dr. Jeffrey Shuren, the center director, spoke about some of the things they were contemplating to take off the table. And they spoke about some of the things like medication adherence software potentially could be off the table, BMI calculators, meaning body mass index calculators, drug formula, drug dosing calculators. That would have been very helpful for the industry.
Okay.
Can I add something?
If you're real quick, because I'm over my time. But
Well, we're hearing from developers and hospitals and docs that a lot of them are waiting on the sidelines until there's final, when are the guidelines going to come out? Is there going to be a tax, until they start developing in the space?
And those are separate issues.
Separate issues, but they're not going forward because they're waiting.
Got it. All right. Thank you all. And I thank the courtesy of the committee we went over. But we'll turn now to Ms. Matsui for 5 minutes.
Thank you, Mr. Chairman. Let me just go through this. The Affordable Care Act was carefully drafted so that not add to the deficit, and imposes small taxes on a wide range of industries that will benefit from the expansion of health insurance coverage for nearly 30 million Americans under the reform. Now, one such levy is a 2.3% excise tax on medical devices. Now, let me just, without getting into the merits of the device tax, I'd like to ask some questions to clarify quickly the applicability to smartphones, tablets, and app stores. Mr. Thompson, is FDA proposing to regulate devices like smartphones and iPads or app stores like the iTunes Store?
I think in the draft guidance, they did about the best they could to explain no, that they don't want to regulate those articles if they can avoid it.
Okay.
Admittedly, it's not the model of crafting, but I think their intent came through.
Okay. So if the FDA is not regulating smartphones, tablets, or app stores, would they be subject to the medical device tax?
So if they're not medical devices, they would not be subject to the medical device tax.
So, Mr. Thompson, it is also my understanding the IRS looks at something called the retail exemption
Right.
when examining the applicability of medical device taxes. Could you explain that exemption?
Well, the exemption is meant to cover medical devices that are basically sold at retail for use by lay people in managing their health. And so those are exempt from the tax. And it covers most things other than, for example, the professional use apps that we've referred to a few times. So whether it's for reading an ultrasound image for a doctor or whatever, those apps would be subject to the tax. But stuff sold to consumers through the App Store would not, as I understand it.
Mr. Chodar, you stated in your testimony that a fair reading of the final regulations implementing the tax should lead one to conclude that the retail exemption applies to all smartphones and tablets that are on the market today. So do you agree with Mr. Thompson that based on current IRS rules, smartphones and iPads are not subject to the medical device tax?
Absolutely, Optique agrees with that.
Okay. So from all you've stated then, smartphones and tablets will not be taxed as medical devices. Now, I understand, in a sense of the frustration here, and I'm frustrated too regarding the draft 2011. And I agree the FDA needs to move swiftly to finalize the mobile medical app guidance. I understand that. The clarity of the final guidance can improve confidence for investment and bring new innovative applications to the consumer. And I wholly agree with you there. And I think we really need to encourage that in a very expeditious manner. I want to move on to something else here. Spectrum is something I'm very much involved in. And we're all involved in this committee. We understand how important that is and how important we need to free up the federal spectrum. Mr. Spalter, your testimony discusses the importance of making more spectrum available to expand mobile broadband, and I couldn't agree more. Do mHealth applications have particular spectrum needs? Are hospitals and other healthcare providers going to be affected if we do not address the looming spectrum crunch?
I believe profoundly yes. Mobile health applications are at their nascent stage now. We're expecting there are going to be extraordinary levels of adoption, innovation, new products, new services, new applications brought to the market. And we need to have a predictable and reliable continuum of access to spectrum for enabling and deploying these innovations. Similarly, for hospitals, patient communities, professional healthcare providers, the need for secure, reliable, profoundly strong, and scalable networks is only going to become more important.
So
and that's based on the availability of spectrum.
Right, exactly. But the unlicensed spectrum is also necessary for you, too, correct? The innovation aspects of it.
Both unlicensed and licensed spectrum are going to be critical to advancing the prospect and the promise of innovation in America's healthcare.
So you think that this is going to be the future, and in essence, as fast as we can do this, the better it's going to be?
The President has spoken about the fierce urgency of now. For the sake of our patients, for the sake of our families, nowhere is that urgency more important than in the health care of our citizens, and mobile innovation based and built on spectrum assets and reliable networks is what will get us there.
Okay. Well, thank you very much. I see my time has exceeded. I yield back. Thank you.
Thank you. I now turn to Vice Chairwoman Blackburn for her questions.
Thank you, Madam Chairman, and thank you all again for being here with us. Listening to you all and listening to some of the questions, I think that we're kind of walking through a period of the what-ifs. And some of the what-ifs are, well, if it's light touch, if they stay out of our business, we're going to do this. And if it's over-regulating, talk to me. If the FDA says, we're going to go after the device, all of our mobile devices, as well as go after some of these 80,000 apps. What is that going to do? Because we're talking about a gross receipts tax, not a tax on your profits. So talk to me, if they go heavy-handed on this, does it stifle all the innovation? Does it shut it off? Anybody that wants to speak, raise your hand, and then I'll recognize you, and go right ahead.
The problem is that there's a risk to developing any kind of a medical application or medical device. For investors to come in and to provide the investment capital, they have to see a reward. Sooner or later, reward is going to be based on profits, but in the early stages, it's going to be based on gross revenues. If you cut the gross revenues, first of all, you cut the valuations of the company. They become less valuable and less likely to be acquired.
So then it's like anything else. The money is going to find an easier path.
It will find an easier path.
Okay, that's I appreciate that. Anybody, anything else to add to that? No? Okay. I want to, Mr. Chodor, I think that probably you're the one to go to on this. I saw the National Coordinator's Patient Safety Action Plan, and of course, with all of your health information management systems, a lot of that work is done down in my district in Tennessee, and we appreciate that they're there. And I know that for the HIMSS members, many times with meaningful use, you've got the private certifications that are working in that space. Do you think a similar model would work for the mobile medical apps and have it go through that process as opposed to a more lengthy regulatory process?
From Haptique's point of view, we don't think it would be the same, because when you take an app, as we were mentioning earlier today, where it takes a mole and takes a picture of it and it says, is it a melanoma or not, and someone's going to make a clinical decision based on an app, we believe that's something that should go in the hands of the FDA, an organization that has done that, and that should be done by, the government as opposed by private sector. Just like Haptique's certification program, we aren't covering apps that should be FDA. We think those apps, that are really making clinical decision should be regulated.
Okay. Anybody else want to add to that? No? Nothing else? Okay, Mr. Jaron, the IOM recommendations, why did you suggest FDA move forward with its draft guidance?
When did we suggest?
Uh-huh.
We suggested when we offered comments to the agency back in October of 2011. The agency released their draft guidance document in July. They opened up a 90-day comment period, and I believe they accepted over 700 pages of comments from over 100 stakeholders in the industry and the public, et cetera. And we were one of those, meaning Qualcomm Incorporated. We submitted a document, which I actually appended to my written statement, so you will find it at the back of my written statement.
Okay, then you and Mr. Thompson, let me ask you this. Do you think the FDA or Congress should set the policy on how we move forward with IMS regulation?
IMS regulation?
Yeah, with the management systems, health management systems, the mobile apps. Do you think it should be us or FDA?
I think FDA is squarely within its jurisdiction right now to move and to act, and that's what they had begun to do. We took a lot of their initial actions as a very promising indication to the industry at large that they were willing to work with all of us.
Okay, let me get Mr. Thompson in before we...
I agree with Mr. Jaron. I think FDA is taking a fairly measured look at health information technology and is trying to do, in some ways, the least that they can do in the hopes of allowing innovation to flourish as much as possible. So I'm optimistic. Now, having said that, I want to see the document, right? Because
kind of back to Dr. Doggy's point that, if the overreach is there, the money, the VC, the funding stop.
Right. We need to see the document. But that's the sentiment I'm getting.
Yes, I now turn to Mr. Waxman. Thank
you very much, Madam Chair. First of all, let me say that I agree that innovation is important, that overregulation can harm public health just as underregulation can. I think there can be great value in discussing how to determine the correct balance and how to achieve it. But when I read the Republican memo for today's hearing, I got the impression that the only two issues of interest to my colleagues on the other side of the aisle with respect to health IT are whether the FDA will inhibit innovation and whether all of our smartphones will be subject to a device excise tax. I understand Mr. Walden agreed with my earlier statement that there is a federal interest in ensuring patient safety, and I very much appreciate that. I'd like to hear from our expert witnesses whether you think there is a need for any FDA oversight of any mobile medical apps. In my opening statement, I mentioned the example of the apps that claim to be able to educate the consumer as to whether a mole is a sign of a melanoma. Clearly, if such an app is accurate, it could lower health care costs by minimizing unnecessary trips to the doctor for benign moles, and could save lives by encouraging people to go to a doctor when they might otherwise have ignored a mole that could kill them. On the other hand, an app that is inaccurate can do just the opposite. So, Mr. Choder, do you think such an app warrants going through an FDA pre-market clearance process, just as it would have to do if it were a conventional standalone medical device?
Yes, we believe that any app that's going to make clinical decisions should go through like an FDA type of program.
Thank you. Mr. Thompson, what do you think?
I agree with that. I think if you look at the 80 apps, for example, that have already been submitted to FDA, they represent fairly high-risk technologies that should be reviewed by FDA.
And Mr. Jaron?
Yes, I would agree with that assessment as well.
Mr. Spalter, do you agree?
I do agree. I think that the important issue, in addition to whether there should be pre-approvals, is we also need to keep our eyes and our minds focused on the costs to application developers for going through those approval processes, the time it takes, and the importance of having a precedential document finally that will set forth the clear guidance and outline and suggest what the real balance is between assuring, as we need to, patient privacy and security at the same time of not inhibiting innovation.
Okay, good points. Dr. Daghi, do you agree that there ought to be an FDA pre-market clearance for some of these devices?
Absolutely. There's a balance between innovation and patient safety. Patient safety comes first, and the balance has to be there as well.
And then Dr. Ford, do you agree or disagree?
Sure, there's a balance that has to be maintained. I think it depends on perhaps what representations are made by particular applications, things like that.
Okay. To Mr. Thompson, in Mr. Jaron's testimony, he stated that 500 new mobile health apps are being launched every month compared to 400 apps that were being launched every month just a year ago. Those statistics indicate to me that the mobile medical app industry is growing at a healthy rate. We all want to see this pace of innovation in the mobile medical app market continue and accelerate. Do you think that the certainty of final guidance from FDA would help the mobile medical app industry continue to attract investment?
Absolutely. Getting a document out there in final form will relieve a lot of the uncertainty, and I think folks who've been sitting on the sidelines will be encouraged to jump in at that point.
Are the members of your coalition concerned that FDA has plans to aggressively regulate this industry, or do they just want certainty?
It's a little bit of both, in all honesty. For the most part, we want certainty. We always live in some fear of overregulation, but we haven't seen any evidence of that. So as of right now, we feel pretty good about it.
Good. Mr. Chodar, you discussed Optique's app certification program and the need for an objective validation process for mobile medical apps. Do you see Optique certification as a substitute for any and all regulation of mobile medical apps?
Absolutely not. It's an add-on.
And what types of mobile medical apps should be subject to FDA oversight?
I think anything that's going to make a clinical decision, anything a doctor is going to use or a patient is going to use that can lead to surgery or a clinical decision.
Do you believe an unfettered market creates incentives to ensure patient safety? And if not, who should step in to ensure patient safety?
It's a great question. I think it's a combination. I mean, in that case, there's place for the government and the federal agencies to participate in that, and for the public.
Of course, if a patient and a doctor can't trust the efficacy of a product,
right,
it's not going to do much good.
Exactly.
Thank you very much. I yield back my time.
Thank you. I now turn to Mr. Latta for his questions.
Well, thank you very much. And just following on, I think that as Chairman Walden said earlier, we make sure that there's a clear line out there for patient safety. And we also agree that there's the need out there for FDA to ensure that patient safety, but we also have to make sure there's a clear line to make sure that those apps that are out there that need to be regulated and those that don't have to be delineated. And I think that's what we're hearing from our panel today. And I just want to, again, as I had mentioned earlier, thank you all for being here today, because, again, I think it's an excellent panel and excellent information that we're receiving here today. And if I could just start, and it's Mr. Choder, make sure I pronounce that properly. I'd like to go back to what you said a little bit earlier, that saying that there's a clear need for the FDA to be reviewing these regs sooner or later. Would you want to just go into that a little bit?
Well, it's been, July 2011 that they came out with their draft guidelines. Comment period came back. The public needs to know, the developers need to know, hospitals need to know, doctors need to know what's going to be regulated, what's not going to be regulated. Right now, we're just sitting in this middle ground, and no one knows. And I think that's the scariest part, because the longer it takes, more apps are going to be developed, and should they be FDA approved or shouldn't they be FDA approved, nobody knows.
Well, let me go to Dr. Daghi.
Yes, sir.
And thanks very much for your effort. Many of us know what it's like to be on planes that are delayed or canceled, so we appreciate you making the effort to be here today. Just following on to that, when you're looking at on the venture capitalist side, if folks don't have that line out there knowing how fast these things are going to be approved, what's that going to do for folks wanting to invest into these apps into the future?
It's going to increase the risk of investment, and venture capitalists will put their money elsewhere.
Okay, and when you say putting their money elsewhere, does that mean, as I think there was also mentioned a little bit earlier, taking that money offshore to have these apps developed?
They might.
And, in your testimony, you were giving some numbers. How much money are we talking about, do you think, that these medical device apps would be bringing in for venture capitalists that they'd be investing into in a year's time?
That's a hard number to get a hold of right now, because there are a number of things that may or may not be medical apps. We don't know whether the extension, for example, of patient engagement is a communication or whether it's a medical device. But probably, I'm sure we're talking about hundreds of millions of dollars, but I can't give you a specific number at this point.
Well, following up a little bit, when you were just talking about folks wanting to make an investment in this, what about when they have to look at that 2.3% medical device tax, and they have to add that into the equation? What's that do to an investor?
If 2.3% is taken off the top, you have a regressive and repressive tax that's going to tell the venture capitalist the return that you can get investing in this area will be curtailed at the very early stage, at the very vulnerable stage of company development. That's the fear. The risk increases.
And Mr. Jaron, again, thanks for your testimony today, too. And also, I think that Chairman Walden brought this up, that it's really looking at, again, on the FDA side of, not getting these things done quickly and slowing down that development. And when you talk about slowing down development, again, as you just heard from Dr. Daghi and Mr. Choder, what's that tell people out there if they want to get into this or not? I think the chairman had mentioned a little bit earlier about, does that mean somebody doesn't get into the medical device app side and they go in to develop, some type of a game or something like that? What's that mean to the industry?
Well, it's really tough on the industry. I've got a great example. There's a company out in California called MedCell, which changed to Vocell, that had an application called the Pill Phone. And they brought it to market, and in construction with the FDA, they actually approached the FDA and said, we're thinking about making this app, and we'd hope that you can help us make this app. And they ended up being a regulated app. The CEO of that company claims that was very helpful to them because it made them make a better product. However, the FDA has mentioned that those apps potentially may not even have to undergo through regulation. So he ended up spending several thousands of dollars, well into the hundreds of thousands of dollars, to go through all of the good manufacturing practices and quality systems to actually ensure that it would really fall under the FDA guidelines and regulations. And if, in fact, he wouldn't have had to go through that, then that's a major capital expense that he incurred, technically for nothing. But we can also argue that it was actually better because his product came out better in the long run. So we have to weigh both sides, but I think that it's very hard on the industry not knowing whether or not you are or are not going to be regulated, because you have to take that into consideration.
Thank you very much. And Madam Chair, I see my time has expired, and I yield back.
Thank you. I now turn to Mr. Lujan for his questions.
Thank you very much, Madam Chair, and to everyone that's here today. We really appreciate your time today. Mr. Choder, I think that the questions have been asked, but I think some, just for clarification, because of the memo that we received about today's hearing, I think that's why you're getting a lot of similar questions, just to make sure that we're able to get answers to these questions. Do you think that some types of mobile medical apps deserve different levels of scrutiny than others? And
yes, I do.
And is there anyone on the panel that disagrees with that? I don't hear anyone. That's good to hear. For example, some apps might not need any pre-market oversight, as you've described. For some apps, consumers and health professionals might expect a version of a voluntary good housekeeping seal that is adequate, like your organization is providing, and some apps might warrant a little more mandatory federal oversight. Do you think the FDA's draft guidance recognizes these distinctions?
I think they do. We can't wait to see the final guidelines.
Well, and I appreciate the testimony today, because one area where I've seen agreement by the entire committee today is that we want to push the FDA. We want the certainty associated with this document to be put into final form, so that way we're able to move on and work together. With that being said, Mr. Thompson, you mentioned in your testimony that there's already 40,000 apps available on smartphones and tablets under the broad mHealth category, and we saw them double just last year. Have you seen any slowdown in mHealth innovation since the passage of the Affordable Care Act?
I haven't seen any slowdown. I'm not in the best position. I think actually Mr. Jaron follows those statistics better than I do, but in my impression is that it's growing quite rapidly.
With that being said, Mr. Jaron, have you seen a slowdown?
No slowdown at all. As a matter of fact, it's almost like a hockey stick. 2 years ago when I formed our comments to the agency, I believe that the figures I was using were about 13,000 apps in one of the app stores and 10,000 in the other, and those were not unique apps. When you hear the current statistics of 40,000 apps, I think it's even higher. It might be actually 45,000 apps, but some of those are the same company, just different types of the same app in essence, so you can't really count them as unique. My understanding from Moby Health News, which is one of the sources for the industry right now, is that there are 27,000 unique apps, so in 2 years it's basically doubled, and that's just unique apps. So I see no slowdown at all. I think that this is a very dynamic, vibrant space.
I appreciate that, Mr. Jaron. And the memo that we received today said that the Food and Drug Administration could potentially classify smartphones and tablets that run the apps as medical devices. I think that's one of the reasons that we're here today. And when you look at the FFDCA Section 201H, it states that if a device addresses the diagnosis of a disease or other conditions, or in the cure, mitigation, treatment, or prevention of disease, that it could be subject to one of these classifications. I just bought these really great pair of Nikes that have this little chip in them that communicate to my phone. So do we need to provide clarification that shoe is not going to be classified as a medical device?
You speaking to me, sir? Yes.
Mr. Chairman?
No, because that's a general health and fitness type of device. They're not.
I appreciate that, and that's the point that I wanted to make today. Is when I ride my mountain bike and I have a Bluetooth connection to it, and it sends some information to me. My doctor said, Ben, you've gotten a little bit chubby since you've gotten to Congress. You need to start watching what you're eating. You need to start running a little bit more. And so these other devices that are communicating to my mobile device, I think what's been clear today is that there's no evidence, even in what the FDA has put out, when we talk about a difference between component manufacturers and device manufacturers, that there's a concern there. But we can all agree again that we need to push the FDA together. And lastly, Madam Chair, as my time expires, I hope that there's agreement with the committee and we work with the chairman and ranking member Waxman that we put as much pressure as we can on the FDA to get this document out. That I heard a lot of concerns from my Republican colleagues about the 2.3% tax. And I completely hear their opposition to this. I'm hoping that they can join me in voting against the Paul Ryan budget this week, because The Republican budget released last week relies on the revenue generated by the medical device excise tax to achieve its revenue targets. So, look, there's some ways to talk about this today and some ways to show opposition, but when it's included in the blueprints associated with the future of what we're looking at here, there has to be a better way to do this. The only good thing I can say today, Madam Chair, is that I think we've seen some clear agreement in this area. And just one last thing, when we talk about the apps, even on the startup companies and the concerns associated with the 2.3% excise tax that was included in the Affordable Care Act, there's one other thing, that startups making retail mobile applications have an explicit retail exemption in the law that excludes these types of apps along with products like contact lenses and hearing aids. That's the truth. So we as members of Congress also need to be careful with how we create uncertainty when we're out saying things that sometimes mislead the public, and I hope that we can work together and make sure I can join with some of my friends and use those new Nike shoes and go for a little jog. Thanks, Madam Chair.
Thank you, Mr. Lujan. And I would like to say, as far as clarity and factual information, the Ryan budget does not, in fact, do that. I now turn to Mr. Shimkus.
Yeah, it's a nice attempt. We just think it's important to balance your budget by 10 years and start paying down debt. So I guess if balancing the budget in 10 years and not paying down debt is not important to you, then I guess, you go to your processes. But
will the gentleman yield?
No, actually not. I was going to try to ask for time, but I think I'll use mine on this debate. But to Mr. Dagan Ford, and follow up to my colleagues' other questions, talk about that chip in the phone. Does it? I mean, he's assuming that the whole panel agrees. Where do you stand on what could happen, Mr. Daggy first and Mr. Ford, with that example that my colleague just expressed?
Depends on the application, sir. If you have, for example, chips in shoes that can be used for a runner but can also be used to look at a child with cerebral palsy and use it to treat them.
My colleague's not paying attention to your answer, and since I would hope that he would do that. Go ahead.
If the same chip can have multiple applications, and traditionally the FDA has regulated applications and claims as well as devices themselves. So the safety piece of it and the efficacy is one part. The second part is the application. We would ask for clarity on the way these are going to be regulated, and we would ask that the goalposts not be moved in the process of bringing devices to the market.
Mr. Ford?
Well, I think it's interesting that we keep asking the FDA for certainty about things, and then we make certain claims about what they will or will not do. It's got to be one or the other. We either need certainty or we don't. The other issue with uncertainty that I think is important to clarify, resolving the uncertainty is not helpful in itself. What if we become very certain that they intend to regulate everything very heavily as Class 3 devices and tax mobile phones and everything else? I don't think that would be very helpful for innovation. So resolving the uncertainty issue depends on what we become certain about and what we remain uncertain about. So resolving uncertainty is not really that helpful if we become more certain that the regulation is going to be very heavy-handed.
And that's a great segue. Just in following the comments, Mr. Jaron, not a correct, but you talked about the hockey stick, all these new apps. How many of you actually have apps right now? And what is the approval process to have an app right now?
It depends.
None.
Why do you think we have so many apps? Now, I've got my iPad here. I've got 21 updates app updates that if you had to go through, and let me ask another question. How often do you update an app? Mr. Choder?
I mean, all developers do it different. Some developers update it 3, 4, or 5 times a year. Some developers are only updating once a year.
So if you have to go through the same regulatory regime on approval of the original app and then all the updates, doesn't that segue back into the uncertainty, the risk, the raising of capital, and that is a problem? Would you agree?
If the app is going to make a clinical decision, then it's the cost of being in a heavy regulated industry called healthcare, where we're dealing with patients and physicians.
But you're living in a world right now where you don't have it, right?
Well,
that's right. We're in a new world, a new brave world of healthcare delivery that everyone's going to be happy with. But health apps developed in the absence of Obamacare, and they are plentiful throughout the system. And our concern is, as the federal government gets involved, it creates uncertainty. It raises the cost of capital. It slows up the delivery process, and it could be very problematic for delivering the same care that we are all espousing. Mr. Daggy, you're nodding yes. Do you would agree with that?
Absolutely. I believe that the medical application can be seen as a provider extender in some cases. So we don't have enough primary care physicians. We don't have enough specialty positions. This is a way of getting to the patient.
So we're all saying the FDA should publish final guidance to clear up confusion. However, Mr. Daggy, you noted that we should be looking at alternatives to the FDA framework. I mean, there's some of us that realize government's big, costly, bureaucratic, slow. The telecommunications subcommittee, the great thing about this sector is it moves faster than we can regulate.
Yes.
And this is a concern that we're going to slow it down. Mr. Daggy, do you believe that the FDA framework is the best way to balance patient safety and innovation in this space?
They have the credibility and the experience. They need to take information outside the FDA. It can't be positivist. It can't be only from the inside. But with the appropriate inputs, yes.
They need to bring the tech community in and be tech savvy, and that would be helpful.
That's correct.
Thank you, Madam Chairman. I yield back my time.
Thank you. I now turn to my colleague, Mr. Gardner, for his questions.
Thank you, Madam Chair, and thank you to the witnesses for joining us today at this hearing. A couple of weeks ago, I met with a constituent of mine in Colorado. He was a software developer in his earlier years, and since has focused his attention on developing applications for a variety of uses. And one of the things he was talking about, recent healthcare scare that he had a conversation with a doctor in Colorado where the doctor was showing him some of the new technologies that he is able to use today and when it comes to medical applications, apps, software apps, things like that, but also in the near future, things that we will be using. And he described a scenario where you could walk into your bedroom and you would have a scale, and you would get on the scale and you'd check your weight. That scale would have a Bluetooth connection to it, to the iPad, and it would send your weight to the iPad. And then you could actually use the iPad for as little as $100, I think you said, with a device that was attached to it where you could check your blood pressure, your heartbeat, your heart rate, oxygen levels, and that would collect it out through the iPad as well. There may be some other things in the room that you could have that would also check your health status. And then that would send it through Bluetooth to the iPad. It would collect it and then send it directly to the doctor's office. At what point then are any of those things an app that could be subject to regulation, subject to a device tax? Would the scale qualify at that point as a device? Mr. Jaron?
The scale would qualify as a device if it's a medical device, if that's the intended use of the device. There are medical grade weight scales and there are non-medical grade weight scales on the market.
So, but just if you had a scale that was attached to Bluetooth, then that scale would become a regulated medical device.
Not necessarily. It happens to you need the intended use from the manufacturer.
So the intended use would be just you go buy a scale, and the intended use is to check your weight. That's what
Correct.
a scale is. That weight then gets sent. Is that a medical device?
Not necessarily. It depends, again, on the intended use by the manufacturer.
So not necessarily, but it could be.
Correct. It could be.
Okay, so there's no clarity there.
Well, what we would need is more information about what the manufacturer intends with.
Well, it's intended. It's a scale. It's intended to check your weight.
But there are some scales that are just for informational purposes, and there are others that are.
Well, all scales are for informational purposes.
Correct, but some make medical claims, and if that's
a medical claim, as in you weigh 150 pounds, which clearly I do not.
Pounds, but this could be used for medicine.
But aren't scales used for medicine?
Not all.
Well, why would you check your weight then?
For informational purposes, you want to lose.
For informational purposes, so it's like reading the description of a coloring box. This is red. This is blue. This is yellow. That has nothing to do with the color. It just is information.
It's information.
That makes no sense to me. A scale is used to check your weight. Dr. Daggy, At what point does everything in your room then, the Bluetooth connection, the iPad, could it check your oxygen level? Is the scale a medical device subject to a tax?
You're 72 years old. You've just come out of the hospital with congestive heart failure. If your weight goes up 6 pounds, you may be about to go back into the hospital with another cycle of congestive heart failure. That scale has to be sufficiently accurate and precise to be able to adjust your medications, and at that point it becomes a medical device. If you put a penny in a scale at an arcade, that's not a medical device.
Okay. So is there clarity, though, of whether the iPad at that point that collects the information from the scale?
Depends on whether the iPad has a built-in algorithm that does something with the information. It's not only the data, it's converting the data into usable information and how that information will be used.
So I'm hearing from several of the panelists that it depends, it may be, it might be, it could be, depends on the... To me, that's not clarity. To me, that means that you have an entire room of iPhones, iPads, BlackBerries that communicate with each other, but it just depends on whether or not something is used for its intended purpose, and that doesn't sound... Dr. Daggy, is there the clarity that we need in this field to ensure innovation?
We do not have the necessary clarity.
And Mr. Jaron, would you agree with that at that point?
It depends.
It depends. That's not. It depends is not clarity. I mean, if it depends, that doesn't seem to me to give you the kind of certainty in innovation and funding the kind of medical innovations that we're seeking.
There's insufficient clarity with low-risk medical devices, or low-risk devices. There's insufficient clarity.
But if low risk a scale?
Yes, could be. If it's recreational purposes. Sure, if it's recreational purposes. If the scale manufacturer is saying...
Mr. Spalter, so I mean, is there sufficient clarity in this realm to know that there's the innovation can continue unfettered?
Clearly not, and we have a group of experts here that are struggling with this question. Imagine what it must be like for the members that we represent, the app developers who are sitting in their laptops in their living rooms trying to dream up the next innovations. How are they dealing with this level of uncertainty? What we're asking for is not necessarily one framework or another. What we're asking for is let's create that balance. Let's find the line. Let's put down on paper where we actually, what we need to understand. And once we get there, I think the hockey stick that we talked about, 40,000 medical apps, will become 100,000, 200,000 medical apps. In fact, I would even say that if we had that clarity, that the smartphone that is enabled to test your analysis that we talked about earlier today, there would already be 3 or 5 new apps that have been developed just this morning.
And Madam Chair, if I could just ask one follow-up. So, I mean, the line clearly in the wrong place at this point, and we've got to adjust it. Is that what you'd agree with that, Mr. Spalter?
I believe that we need clarity, yes.
Dr. Daggy?
Yes, sir.
Thank you. Madam Chair, thank you for your indulgence.
Thank you. And I will finish. Mr. Lujan, did you have additional questions or comments that you wanted to make? Okay. I will finish up with my questioning. And Mr. Thompson, I have a question for you. In the wireless world, most wireless devices are replaced in a 2-year cycle, and mobile operating systems are replaced in as little as 1 year by their next version. I mean, having considered the high rate of technology advancement that's taking place. In your experiences with the FDA's regulatory processes, how long does the pre-market approval process take, on average, for a non-invasive medical device?
There's quite a range, but the range could be anywhere from about 90 days at the earliest for the actual FDA review to up closer to a year and a half would also be reasonably typical.
And so basically, so a year and a half, so that's time that's gonna elapse before some of these very important medical applications can be put forward. I would just like to finish up by asking all of you to respond to a couple of questions. Yes or no or unclear. I would like the response. I think one of the things that this very important subcommittee hearing has really brought to light is, one, we all care about patient safety and we want to practice appropriately. We agree that there is FDA approval and regulatory processes that need to be in place for certain levels, especially when we're looking at something as important as diagnosing a disease or, something very important. And Mr. Spalter, I listened to your testimony, and I have my own personal experience with diabetes, and I can only think my older brother was diagnosed 40 years ago, and where we would be today had we had some of that innovation in place. So if we're adhering to all of these things, the other area that I think we all have agreement on, and this is one where I would like to start to get a yes, no, or unclear answer, is do you all agree that it is still unclear where we are with what is a medical device? Starting with Mr. Jaron.
Yes.
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 Yes. Yes.
Yes.
The other question that I have for you is this. Again, FDA regulation and medical device tax or gross tax. These are the two issues that we're really talking about today. In your opinion, if it is FDA regulated, should the medical device tax be in place? And again, I guess I should preface that by saying, do you believe that the medical device is going to hamper innovation? And I would like for each one of you to answer that question first.
Unclear.
I would say it definitely hampers innovation.
Unclear.
It's still unclear.
Definitely yes.
The tax will hamper innovation.
In your opinion, then, my last question, if FDA regulation is in place, and certainly, we've seen the need for FDA regulation. I mean, I'm a nurse. I get it. We need to make sure we're practicing safely and best practices are being adhered to. Do you believe, if the FDA regulation is in place, that a medical device tax for such a product should be in place as well?
Unclear.
We oppose the tax.
Unclear.
Unclear.
Separate the tax from the regulation.
Two completely different questions.
Thank you very much. I truly appreciate the testimony that all of you have given here today. This really opens up that door on this discussion that we really need to have as to whether or not this medical device tax is something we need to move forward with, and, of course, all-important FDA regulation. So thank you very much.
Thank you.
Thank you.
This committee is adjourned.
Share with you my 16th century personal